My name is Valerie Gideon. I'm the Senior Assistant Deputy Minister responsible for Health and Indigenous Services Canada. I'm Mi'kmaq from the Gueskipeguiag First Nation.
My name is Dr. Tom Wong. I'm the Chief Medical Officer for Public Health for Indigenous Services Canada.
We're here to provide you some overview information about the COVID-19 situation, as well as to share with you more specifically what Indigenous Services Canada is doing to support Indigenous communities, in particular First Nations communities, with respect to the COVID-19 response. Dr. Wong will start by providing you with an overview of the global and domestic COVID-19 preparedness efforts.
Thank you. Canada's public health system is prepared. The Public Health Agency of Canada, along with public health authorities at all levels of government across the country, have been working together. The Public Health Agency of Canada is working with provinces, territories, and international partners, including World Health Organization, to actively monitor the situation. Global efforts are focused on containment of the outbreak and the prevention of further spread. The federal, provincial, territorial public health response plan for biological events has been activated to ensure a coordinated response across Canada. The provision of health services to Indigenous peoples in Canada is an area of shared jurisdiction. Under the Canada Health Act, provincial and territorial governments provide insured health services to all of their residents, including First Nations and Inuit.
It is important for us to work as one system and to work in a coordinated, collaborative, and transparent manner, particularly with respect to Indigenous Services Canada. We recognize the particular geographic, systemic, and policy-related challenges that can be faced by Indigenous communities, and specifically First Nations, Inuit, and Métis, who may have more limited access to healthcare service providers, as well as other social determinants of health challenges. The Government of Canada is generally responsible for the provision of services for First Nations on reserves across provinces in Canada and provide primary care services in remote and isolated First Nations communities where there are no provincial services available. There is a distinction in British Columbia where in 2013, the British Columbia First Nations Health Authority took over responsibilities that were previously held by the federal government for those primary care and public health services across all First Nations communities in BC. We also support the delivery of public health and health promotion services on reserve and in Inuit communities in Inuit Nunangat. And in addition to that, Indigenous Services Canada funds drug, dental, and ancillary health services to First Nations and Inuit, regardless of residence, through the non-insured health benefits program. Our relationship with Inuit is different in that we fund territorial governments, land claim organizations, and self-government agreements, and so our role is primarily that of a funder. We do co-chair the Métis Health Committee with national and regional Métis representatives, Health Canada, and the Public Health Agency of Canada, and Métis continue to receive services from provinces and territories directly. In terms of health emergency preparedness, Indigenous Services Canada is responsible for health protection measures and health emergency preparedness for First Nations communities in all regions, and as I mentioned, with the exception of British Columbia, where we fund the First Nations Health Authority. In Budget 2019, the department secured $211 million over 5 years to support increased resiliency and emergency management on reserve. This included specific and the first time ever investments to support health emergency resilience and preparedness in First Nations communities in the amount of close to $80 million over 5 years, with $17 million ongoing. This capacity has been very important to prepare for COVID-19, where First Nations communities and tribal councils and other organizations are able to support First Nations communities in the development and testing of their pandemic plans, as well as knowledge mobilization efforts so that communities can share what lessons they have learned and what are their needs. And that is the foundation of our support services. We also have specific policies and procedures to respond to emergencies in place, and we have dedicated health emergency management coordinators in all of the regional offices, as well as a dedicated secretariat here within the national office. We are working through regional offices, of course, to prepare surge capacity response plans that will relate to additional health human resources that could be deployed in communities based on the significance of COVID-19 in particular communities and their need for additional supports. We are also looking at special capacity supply and response needs, and those would be assessed by communities in collaboration with provinces and also with regional offices of our department. We are in regular communication through the national network of regional emergency management coordinators and regional medical officers of health with communities specifically, whether those are health directors, frontline providers, but also community leadership. And we'll be having and continue to have regularly scheduled calls, conference calls, as well as sharing communiques by our department, but also provincial communiques that are issued by provincial governments on the COVID-19 situation. All of our regional offices have been directed to follow provincial public health protocols to ensure that we are being consistent and coordinated in the approach. All regions also have participated in personal protective equipment training. They have access to a toolkit which is made available also to communities, and they also have an ability to continue to support community pandemic planning that need to be adapted, particularly to how COVID-19 may evolve over time. We also are encouraging strong routine infection prevention and control measures in communities and external service providers and public health measures and education for individuals, for families, as well as for workers in communities such as in the education, healthcare, or other areas where they would be close contact with a number of community members. We are collecting information on occurrence and incidents reporting, relying also on provincial governments sharing their information with us on a regular basis. And we are also encouraging everyone to track their spending with respect to their COVID-19 response measures. I've spoken about communication, but we are strengthening our outreach through social media. We have produced public service announcements in 10 Indigenous languages, and will continue to work on Indigenous language translation of core information. We also have a specific departmental website that is aligned with the Public Health Agency of Canada's messaging. We are trying to streamline communications, but we are really encouraging people to follow trusted sources of information and to validate information where necessary with their contacts in regional offices in terms of health emergency coordinators and regional medical officers, as well as provincial government officials. Of course, there have been lessons learned from past health emergency situations. I myself ran or operated the Ontario region of the First Nations Unit Health Branch during H1N1, and Dr. Tom Wong also has experiences during SARS and H1N1. And some of those lessons learned on which we're basing improvements for the COVID-19 response include having clearer governance structures to ensure intergovernmental coordination specific to the needs of First Nations, Inuit, and Métis communities. Those specific investments that I mentioned earlier to support health emergency preparedness on reserve. Having had preemptive training for health service providers, including in the use of personal protective equipment. Adapting medical transportation policies, particularly for clients that face higher risk factors of complications from COVID-19, so that they can travel in more private transportation models and also accommodations. And also connecting pandemic planning with broader emergency management plans at community levels, and considering the needs, the specific response or preparedness needs for communities who may face national disasters and will need to evacuate into other centers so that they are protected from greater risk with respect to COVID-19 in those settings. having a single window for information, reliance on trusted information sources, and also including mental health services and mental health considerations in community pandemic plans, and ensuring that those have culturally adapted and safe measures. I've mentioned already a number of ways in which we're collaborating with other federal departments through the Government Operations Centre, and also continue to work with the Public Health Agency of Canada on their planning and preparedness activities, including a remote and isolated guidance for the COVID-19 response. And we participate on the ongoing Federal, Provincial, Territorial Special Advisory Committee that reports to the Conference of Deputy Ministers of Health, and have regular conversations with regional offices, as well as including First Nations health authorities as well in those discussions. Dr. Wong, I'm not sure if there's anything further that you'd like to contribute from a technical perspective.
From a technical perspective, I want to actually emphasize that this particular virus does not float in the air. And so as a result of that, the virus actually drops very quickly within a meter or two onto the ground. And therefore, the risk of transmission compared to, say, for example, measles. One case of measles, because measles virus actually floats in the air, you can actually, be infecting 15 to 20 other people. Whereas, for this particular coronavirus, you may, on average, infect, 2 to 3 other people. So it is so important, that, we make sure that, we practice all of the sanitation and hygiene measures, just like, what we do with regular flu season. Including washing your hands often with soap and water, and if that's not available, with hand sanitizers. And again, you cough into your elbow, or if you're using a tissue, you cough into tissue and then discard the tissue properly, and then wash your hands after that. And if you are sick, do not actually come to work or do not, go to school. And at home, if your symptoms get worse, please contact your health providers. So those are just, some of the practices that you can actually follow in order to minimize the spread of this infection. Thank you.
Absolutely. So I think we recognize absolutely that there are communities with significant infrastructure challenges that will not be able to be addressed overnight, and that we need to find pragmatic interim options for those communities. That can include temporary shelter solutions, temporary rapid assessment and testing spaces, whether that is a repurposing of an existing community facility that might be available, or whether it is actually a temporary shelter solution. So those are discussions that we are having with partners, and we are looking at options that the Public Health Agency of Canada, the Red Cross, National Defence have used in the past, so that we would have a supply of these that could be mobilized as may be needed for those remote communities. In terms of self-isolation, we recognize that there is an overcrowding situation in multiple communities across Canada, particularly in remote and isolated communities. And so communities in their pandemic plans should consider what might be options for those individuals, whether the individual remains at home and the other family members might be accommodated in another residence, or if they wish to go outside the community for a period of time, it would be various options that could be considered in addition to the possibility of having a temporary shelter solution.
Different regions have different needs, and different communities have different needs. So one size doesn't fit all. Our FNIP regional offices, will be working with the communities and the leadership of the communities to find the options and the solutions that would work best for the community.
If communities decide to broadly self-isolate and really limit travel in and out to their community, we would continue to support that community in accessing health services. and ensure that there would be proper protocols in place to ensure the safety of the community members with respect to healthcare staff that might come in from outside. And as I mentioned earlier, utilizing more private modes of transportation, particularly for individuals that would absolutely need to come out for access to medical services, whether those are relating to COVID-19 or not. We have received requests for supplies and personal protective equipment. For instance, we've shipped about 242 cases of hand sanitizers. We will continue to receive regular requests. The stockpile that is maintained by the department is intended to supplement what is not available through provincial and territorial stockpiles. The Public Health Agency of Canada maintains a national emergency stockpile. Provinces and territories draw from that, and communities would draw from provincial territorial stockpiles primarily, particularly those communities that operate their own health services. However, that being said, the department is available to be able to provide to some extent additional supplies for communities. We of course maintain a stockpile of personal protective equipment for employees of the department, which is a legal obligation of every employer under the Canada Labour Code. Anything further?
We have the stockpile for personal protective equipment for communities whenever they need them, if they are in an emergency.
If communities have unique needs or needs that they feel they are not clear about how they might be met, it is really important that they reach out to regional medical officers of health at our department or the regional health emergency coordinators and submit any requests or questions that they have. Regional offices will go in person. They will pick up the phone. We understand that we need to balance a diversity of needs. Not every community will be affected the same way. Not every community will want to approach the response in the same way, and that is understood and recognized. At the same time, a coordinated approach is important. If everyone is competing for scarce health human resources or for supplies, that could actually lead to a situation where those that are most in need do not have access to services or supplies. So we have to work together as one system. We thank you very much, and we hope that this information has been helpful in our efforts.